All right, so we are getting to that point. So starting at noon, we are going to be discussing today's webinar. This is the July webinar. We do these monthly. So let me get the topic open. I hope you guys are all excited to learn some fascinating things about traditional cancer screening and where we've advanced in different approaches, more integrative approaches, patient-specific, risk history specific. A lot of wonderful things can be learned from analyzing the blood, especially in the realm of cancer. Of course, none of these different types of screenings that we're going to discuss are meant to completely replace traditional cancer screening and conventional guidelines. However, they are very complementary and in certain types of cancer, really the best avenue towards taking the first step to seeing our overall risk and potentially if we are dealing with any kind of active malignancy. So I hope my screen is sharing well. Let me move my face over here and I'll get into presenter mode and we can begin shortly. All right. So beyond traditional cancer screening, so what are we discussing today? Well, first off, I'd like to introduce myself. My name is Dr. Ram. I'm with Regenerate Health Medical Center. Like I said previously, we do these webinars monthly on a variety of topics. Generally speaking, they're meant to be educational as well as orient individuals to sort of our clinical approach and why potentially you might want to work with us, depending on your health needs and health concerns. So for today, we are understanding today's options by asking the right questions. We're not trying to find a single best test. This is not about one best cancer test. This is really about asking the right clinical questions. So we're going to be talking about covering prevention, treatment, and even preventing reoccurrence in today's lecture. So for traditional screening, we have seen it save millions of lives. Routine cancer screening remains the foundation for early detection. We're discussing mammograms, colonoscopies, cervical screening, PSA discussion, as well as looking at the lungs. There are obviously skin exams that help us point towards having more investigation, biopsy, and all of that. However, what I want to highlight here is there are only 5 routine cancer screenings, and this is something patients are very surprised by. When we're talking about what's on the list, we are talking about breast, colon, cervical cancer, lung cancer, in certain patients, and prostate. So everything else, what else is there? There's obviously pancreatic, ovarian, kidney, liver. Many of these offerings do not have traditional cancer screening guidelines. We can take some time to look into a patient, especially if they have a higher risk profile or previous malignancy in those regions. But generally speaking, we don't have these guidelines set in stone. And when we consider about 70% of cancer deaths occur from cancers without routine screening, there is a need. There is definitely a need. So there is this gap. We call it the screening gap. As I mentioned before, those 5 we're routinely screening for. While many advancements have been made in terms of how to crystallize those guidelines to give our patients the best opportunity to really rule out malignancy or do a deeper dive if there were to be a positive result coming back. We're still struggling with, like I mentioned, those 70% of cancer deaths that occur from cancers that don't have routine screening. So generally speaking, the modern screening gap comes from the inability to give a blanket assessment, blanket guidelines that tell us this is how we rule out whether you have malignancy or not based off of insurance coverage, based off of yearly or biannually routine scans, routine screening. Those just don't exist for a large portion of the cancers that do cause death. One reason why is we do fairly well nowadays with early stage cancer diagnosis and 5-year survival rate. We're seeing those early stage numbers being up to 90% 5-year survival rate for those who've been diagnosed in that early stage. Unfortunately, that number does drop to about 25% 5-year survival rate for those who have been diagnosed as a late stage cancer diagnosis. So that's some of the concerning factors when we're talking about the lack of screening options and really where do we go? Where do we go when we're unsure if we're potentially dealing with a malignancy situation, but we don't have the proper protocols to consistently rule out cancer in certain populations? And this is where medicine is asking better questions. We are no longer just asking one question Do you have cancer? Do you not? We are asking, am I at a higher risk? This is dependent on a variety of factors, which we'll dive into, some like family history, genetics, lifestyle, individual biology. But also, can my treatment be personalized? This is when analyzing the tumor biology gets very, very fascinating. We're talking about targeted therapies, precise medicine, and individual treatment selection, anywhere from immuno-based therapies to really finding what chemotherapies are going to be highly effective for that particular tumor biology. Not saying that it's always going to be a one-to-one. If a tumor biology shows sensitivity to certain types of chemotherapy, we don't always see that follow through with patients, but it starts putting us in the direction towards getting more personalized, precise medical care. And then lastly, another question we're considering is how should I be monitored after treatment? We're trying to detect recurrence earlier if it is to come back at all, but we're also trying to track therapy response, guide ongoing surveillance. There are different clinical questions that require different diagnostic tools. And while we're on the topic of questions, I'd like each and every one of you today to consider, there are these three questions, these three paths. You may feel that you fall into one of these three, or somewhere in between these three, but you may ask, I've never had cancer. What should I be doing for prevention and screening? You may be thinking, I've been diagnosed. What do I do after diagnosis? What do I do for treatment? Or your path may be, I've completed treatment, survivorship, surveillance are important to me, but how do I put myself in the best position to make sure this never comes back? And if it does come back, what are we going to do about it? And how are we going to approach it any differently than we approached it previously? So diving into this next section, for those who are asking yourselves, I've never had cancer, am I at risk? Well, age is a factor. In fact, age is a major factor. There are studies that show a 13 times increase in cancer risk by the time we reach age 50 and above. So for those with family history, that number might be equivalent for even a 40-year-old and above. This is where the personalized screening and personalized care takes into consideration family history, genetics, smoking, alcohol. That 50 plus that we're talking about might get reduced to 35, 40, depending on the variety of risk factors. But generally speaking, cancer is affecting those individuals who have reached 50 years old or higher. And you'll notice that's reflected in some of our routine screening and even something like a colonoscopy, which has seen earlier and earlier guidelines as the years have gone on because individuals are developing colon cancer at a higher rate in these younger populations than they were in previous generations. So it's a complicated question to say, am I at risk? I've never had cancer. The reality is, in modern lifestyle, the majority of us have a risk factor in either our family history or some of our lifestyle choices, or be it our age, because we're all trying to live long and happy, fulfilling lives with good quality, not just good quantity. And part of making sure that quality of life is there comes from reducing risk factors, but also properly assessing where are we in our health journey when we start reaching these middle-aged years, and just ensuring that we're doing the best that we can to rule out any potential diagnosis that come down the line. Catching it early is the primary goal in this field. So one newer option you may not have heard of in terms of screening is Gallery. Gallery testing is blood testing. So if you've ever been told blood testing can tell you nothing about cancer, we're living in the past with that. Again, like I've mentioned previously, this is not replacing traditional screening. This is complementary. But some of the work that Gallery does is very fascinating in terms of detecting circulating tumor cells. Really what the flow is that traditional screening will continue to be recommended, but a single blood draw, about 20 milliliters of blood, so not too much blood, even less than some of your annual blood draws, you will be able to analyze cell-free DNA signals. This leads to us finding a couple different factors about the potential malignancy if anything were to come back positive. It can tell us the origin, the likely origin, I should say, of where the cancer has developed, as well as the overall circulating tumor cell number, meaning how much of this cancer is shedding into the DNA. The more aggressive cancers tend to shed a bit more frequently. So what we're talking about here is not necessarily detecting cancer itself in the blood. We are detecting cancer DNA as a unique fingerprint. This slide here mentions DNA methylation, right? So detects cell-free DNA signals across 50 plus cancer types, much more than that traditional guidelines for the five routine cancer screenings we have. But the ability for our Gallery testing to analyze DNA methylation, meaning these signals that are on the DNA fragments floating through our blood, can point very reliably towards having a potential cancer diagnosis that has not yet been made, but is being shown through the blood work. Think of this fingerprint as a certain cancer profile. And again, we're not seeing cancer in the blood, we're seeing this profile, these genetic mutations, these upregulations of certain pathways, downregulation of other pathways. It creates essentially a fingerprint that is able to both be corroborated with potential location from where the cancer originated and how fast is this DNA shedding. Because we do see with these more aggressive cancers, there's more circulating tumor cells, therefore more ability to capture an amount of DNA methylation fragments. So what I'm trying to highlight here is that we're using Gallery to say, there's a signal here, and this signal is very reliably telling us that there can be malignancy in the body. So we don't diagnose cancer after this blood work, but we do aggressively look into the options for screening or diagnosing, particularly when we feel very confident that we have an idea of where that cancer cell origin is coming from or that signal is coming from, be it pancreatic or ovarian. We are going to be really analyzing that part of the body and sometimes other parts as well, because it's one of those complicated natures where if we have malignancy, we may be wanting to look in other portions of the body. But the reality is, by giving us a single origin or an area in which the cancer is likely to develop from, we're able to more efficiently target the screening process and the diagnostic process post blood work so we can come to a diagnosis sooner. And just as I mentioned previously, early detection is massive. With my patients, I'd much rather see them coming in with a stage 1, 2, or even 3 cancer diagnosis than that stage 4, because I know our 5-year survival rate is going to be doing much better. And I also understand that we have more time to make a personalized treatment plan that's going to massively affect the patient in a more opportune way in terms of survival and also quality of life, because it's not just about treating the cancer, but treating the whole person, ensuring that individual is capable of being able to tolerate the treatment that's going through their body. And that's really where that individualized care comes in, where that integrative approach shines through. So one analogy I'd like to bring up is similar to that fingerprint. Gallery is designed to look for a cancer signal before symptoms appear and before a cancer has been formally diagnosed. So, who might benefit from a test like Gallery? Well, like I mentioned, with that statistic about 50 years old and up, that really guides Gallery's recommendation. Gallery, from the company Grail, will recommend a yearly Gallery test. So what that might look like is getting your blood drawn once a year, getting that sent in. This would act adjunctively along your typical screenings. And generally speaking, this is not covered by insurance. There is a big push to get coverage from insurances. TRICARE has, without any sort of oversight from any governing bodies that regulate, cancer guidelines or any sort, has electively decided to start covering Gallery testing as part of their insurance plans. But there's a strong push, there is strong investigation towards getting Gallery more accessible for those individuals, especially at that once a year type framework. The Mayo Clinic has been doing studies independent of Gallery themselves, just using Gallery to see what metrics are being shown. Is it leading to earlier diagnosis? Is it leading to better health outcomes? Can it potentially reduce the burden of medical costs that come with these later diagnoses, with these more aggressive cancers that weren't caught earlier than they could have been? So insurance game aside, in a perfect world, we're getting this done yearly after the age of 50. And I endorse what Gallery is saying in this recommendation because we do see that cancer profile risk exponentially increase with age. Of course, genetic factors play a role, lifestyle factors play a role, but when we're talking about the lowest hanging fruit to correlate potential cancer diagnosis with a risk factor, we're really looking at age. So if you come in with a strong family history of cancer or you are a previous cancer survivor, then you may qualify to get this test somewhat earlier, be it from your healthcare recommendation, your healthcare's recommendation, or if you are covered under TRICARE, you may be able to get that coverage a bit sooner. But really, what we're trying to highlight here is that a positive result is not a cancer diagnosis, and a negative result doesn't rule out cancer. We still want to continue guideline recommendations for screening, but this can fit into a plan to ensure that those who are trying to prevent any late stage cancer or catch their cancer diagnosis earlier, they're doing everything they can to ensure that this is being done. This is a test that, like I mentioned, is going to be out of pocket, and we can discuss pricing if you guys are curious about it. Some clinics like the one we have here in Regeneron Health Medical Center get some discounted pricing, about a couple $100s off. But we are looking at around $750 for a Gallery test if we were to go out of network. And what I really appreciate with Gallery is some of the benefits that come from what they offer in terms of making it accessible to patients. So one out of, I believe, 256 people will receive a false positive with a Gallery test. But realistically speaking, that's a fairly good number. If we can imagine 10,000 people taking a Gallery test, about 9,900 will receive no cancer signal detected. So the majority of my patients that I'm running this test through are going to come back with a negative result. And we can feel very confident that we're not missing the cancer diagnosis or the cancer signal. But for those who come back with a positive result, about 100 out of those 10,000 will receive that positive cancer result. Take that positive circulating tumor cell result, and about 62 of them ultimately will be diagnosed with cancer. So 100 positive results out of 10,000 people, 62 of them will become diagnosed at some point with cancer. So that leaves about 38 that are getting that positive result out of the 10,000 that are not going to be diagnosed with cancer after the Gallery testing, even though they came back with a positive result. So what does that look like in terms of the actual care, in terms of retesting? Well, Gallery has a wonderful program where if you do come back with a positive result and we've done the proper diagnostic workup, we can send that information into Gallery as long as we're doing it within 6 months of the positive result coming back. We will see that no cancer diagnosis was made, even with a positive Gallery test. We're going to do a retest. So they're really ensuring that that positive result that came from the Gallery test and then that negative follow-up diagnostic investigation is in fact correct. We're not trying to continuously put the burden on the patient to pay for another test. So they have found a way to comp that. As long as we are going through the proper protocols after a positive test to try and formally diagnose that cancer, and we fail to do so, we will do another Gallery test at no cost to the patient. So that's one of the things I appreciate with Gallery. It's really about giving individuals an opportunity to confidently screen themselves, and then once going through the formal diagnostic process, be sure that they haven't missed anything. So Gallery testing in general, like I mentioned, fairly simple, typical blood work. Really, the meat of it is cost and being able to efficiently and effectively discuss with your practitioner your needs, your risk factors, and the best ability to go forward with treatment because with testing, because like I said, once a year is ideal, especially once we reach age 50 and up. However, if we need to space it out so that it is matching the budget, matching the lifestyle of the individual, we'll do so, especially when we have more additional information in terms of family history and lifestyle factors that can increase or decrease risk levels. So moving on to that second path we've been discussing, I've been diagnosed. What happens next? What happens next? Okay, so diagnosis creates a completely new set of questions. We're talking about a new goal. We're not trying to think about, what's going on in the body. We are more so talking what's going on with the specific tumor biology, and how can we manipulate that biology so that we can ensure the best treatment outcomes for our patients. Before I dive into this, let me stop the share real quick and just see if we have any questions in the chat. Okay, no questions. Feel free to leave questions in the chat, or you can try the raise your hand function, and when I step out of screen share, I'll be able to answer those questions as they come up. So getting back into the slideshow. So if I've been diagnosed, what happens next? Well, Understanding your cancer's biology, like I mentioned, is very important for this step. Tumor profiling identifies genetic mutations driving cancer growth, results guide targeted therapy selection, and treatment begins with understanding the tumor, not just the organ. And what I mean by that is they are personalized cancer profiles. Your treatment should be for you. Patient A with breast cancer gets the personalized treatment plan A, not personalized treatment plan B. That's reserved for patient B. We have a host of different factors that affect how tumors progress in the body, how cancer really wreaks havoc on individuals. Like I mentioned, tumor biology is large. Molecular features, the amount of circulating tumor cells can tell us how aggressive, how much the cancer is dividing and shedding. Overall health, an individual coming in depleted, a long history of autoimmune disorders, potentially malnutrition, variety of stress factors being in their play, is going to respond very differently to treatment than someone who has been proactively working with their nutrition, their exercise physiology, and other factors of their lifestyle that might support their overall health. So this comes with that long integrative, you know, patient visits where we can really discuss the trajectory of where your life has been, where you are now, and where you hope to be. So that's part of the personal goals, and part of understanding that cancer does change over time. And sometimes a treatment option early in the cancer diagnosis may need to be reformulated as we go later on into the treatment itself. So why might a doctor order more than a biopsy? Why might I order more than a biopsy? Well, really, a biopsy is going to give you a nice snapshot of one part of the tumor at a moment of time. It's going to help tell us what type of cancer it is, what does the tissue look like. It is going to help us with staging. But what comes after that is the circulating tumor cells. And what we're going to get into is RGCC testing, which will be in our next slide. This is somewhat similar to Gallery testing in that they are looking and investigating circulating tumor cells. However, we're going from a screening profile to one that offers both screening, but also can guide treatment outcomes. And why is it doing so? Well, we're looking specifically with RGCC testing at how the cancer behaves biologically. We're looking at the living tumor cells, the additional characteristics that come with it, and that information may help complement other clinical findings. So what can RGCC provide that we're not necessarily getting from a biopsy? Well, we are studying the circulating tumor cells. That's measuring the presence, the quantity of cancer cells that have entered the bloodstream. And really what we're trying to look at is certain cancer stem cell markers to see the possibility for that cancer cell to develop and grow more aggressively. We're looking at gene expression to understand how the gene activity is affecting the cancer's biology. And what I really appreciate about RGCC testing is that we're looking at laboratory treatment sensitivity. So what that means is we are actually taking those circulating tumor cells and again, through blood work, sending it to the lab, having them, once properly processed, evaluate these circulating tumor cells in a petri dish with a variety of other types of selected therapies, be it natural products such as curcumin, such as mistletoe, uh, a laundry list. I cannot go through all of the natural therapies that are being tested for the tumor biology specifically, but also traditional chemotherapies, pharmaceutical agents, cisplatins, things that we're consistently prescribing in the oncology field. We're able to actually look at the tumor biology and investigate how they might respond to these different therapies and their sensitivity to these specific therapies. So that's a big portion about what allows RGCC to stand out. They have a variety of different tiers in terms of when you get your blood collected, what tests are we running, what are we ordering. You can very much so look at just the circulating tumor cells and try to investigate tumor origin, how much of the body is really being burdened with the circulating tumor cells. But there are other tiers of testing that actually show once there has been a formal cancer diagnosis, how is the cancer going to respond to different therapies, different treatments? So that's a very big one in terms of why I might opt for an RGCC or why I might look for patients that are curious about this and really explain what we're looking to get out of this type of blood work. Also, other aspects that I like about RGCC is the monitoring over time, using this testing to really see how we're responding to our cancer therapy once we've been implementing a treatment plan and seeing that shift in circulating tumor cells and ensuring that we're not getting a new cancer site origin to rule out potential for metastases and new malignancies being located in the body. And this, again, whole investigation is trying to give you a personalized biological profile. We're combining multiple laboratory findings, multiple laboratory testings in order to individualize a picture of a cancer's biology and thus give someone an actual treatment plan that matches their physiology and matches the biology of the cancer they're dealing with. So this is one of the more interesting forms of how we're using blood to really push cancer treatment and cancer diagnosis. And like I mentioned, what can circulating tumor cells tell us? Possible tissue of origin, biologic characteristics, monitoring over time, we're repeating the CTCs. We're trying to analyze to see, are these coming back at a higher rate? Are they properly reducing over time with treatment? And building a more complete picture. Because one of those things that comes with the sensitivity towards certain natural therapies or pharmaceutical therapies is the ability to create layered treatment plans, especially if we're opting for a purely natural approach towards treating our cancer. We are looking at rotating certain natural therapies or rotating certain chemotherapies based off the sensitivity to the cancer so that they do not become accustomed to it. We find that cancers adapt, and certain mutations allow portions of the cancer to actually survive or linger after a large amount of it has been treated successfully by a chemotherapy. But that bit that has adapted, that's shown resistance to that particular part of the treatment profile, can now be tackled by another type of treatment that has been shown on the sensitivity list. So this is where we get fairly layered in terms of month one, month two, month three. This is what we're treating the patient. Then month four, month five, month six, we're rotating a new set of natural or pharmaceutical, or sometimes a combination of the two therapies to help ensure that we're taking care of the cancer at multiple levels so that any lingering adaptations and mutations, the tricky escape factors that cancer employs to find the ability to recur after treatment, we're neutralizing those by having layered treatment approaches and not just throwing one treatment plan at the patient, but really nesting a plan that builds on top of itself as time goes on. And continuously testing those CTCs is one of the best ways to ensure we're building a complete picture and a complete roadmap that's guided by some of our specific tumor biology and testing that we're employing. So which therapies may be most active against your cancer? So that's kind of what I was alluding to with the different chemotherapy agents, the immunologic therapy agents, the targeted natural therapies that, some may be responding wonderfully to high dose vitamin C, and some may not really have a big response to it. And without this testing, we don't know as reliably as we'd like to. We can work off our clinical understanding, we can work off the research papers, but every person is individual and every person's tumor biology is going to come with its specific profile. So sending your blood into RGCC to do this analysis can really help guide my understanding of how we can best explain to the patient why I want to go a certain direction I want to go and why I find that this direction is going to give the patient the best outcome and the best opportunity to live a strong, healthy, successful life post-treatment. And this is just highlighting the importance of personalized oncology and understanding your individual cancer when we're trying to come from an integrative approach. Okay, so before I move to this section, let me just stop share real quick. Okay. Let's get back to the share. All right. So I've completed treatment. Am I still clear? Now we're on that third pathway. We're talking about survivorship. And just to be candid, we have done a previous webinar on prevention, post-cancer diagnosis or post-cancer treatment, preventing reoccurrence, and how to live life post-treatment. And I'll put a plug at the end of this video, but we are putting these videos, these webinars on our YouTube channel. So you can watch clips on our social media, on Instagram, or you can watch the full-length recording. And we will cover some of the factors that I covered in that 40-minute webinar in this particular presentation. However, it is a more abbreviated version of that 40-minute webinar that we've done a couple months back. So if you feel that you fall into this third pathway and you'd like more information after this, you can obviously go back and take a deeper dive, but just felt it was prudent to include this into this slide set as well. So I've completed treatment. Am I still clear? Survivorship brings new questions. Is the cancer gone? Could it return? How do I stay well? Well, we're building a personalized surveillance plan, and this comes from follow-up visits, routine lab work, continuing tumor markers. Like I mentioned with RGCC, we can continue post cancer care to evaluate if there are any recurring circulating tumor cells. Imaging is very important, continuing to do the imaging based off of what our oncology team has developed, and advanced testing. The Gallery testing, we generally recommend that we reintroduce Gallery testing about 3 years once we're in remission, 3 years post remission, I should say. So you can do Gallery testing as soon as you are declared cancer free. However, generally speaking, I find in my practice, and it is recommended by Gallery, that we wait at least 3 years because of the potential for some of those lingering circulating tumor cells. Doesn't necessarily mean there's still cancer in the body, but we might get a signal. So in general, that 3 year period is helpful for those who are coming back from remission. But there are a host of options. So really, this is probably the most personalized portion of coming back from a cancer diagnosis, coming back from treatment, being declared cancer-free in remission. What are we doing in terms of surveilling our body and making sure that we're also living a lifestyle that keeps ourselves cancer-free and in the best position to continue to live healthy, immune balanced lives where we are not underactive in our immunity, we're not overactive in our immunity, but we're properly allowing the body to assess risk factors and eliminate cancer before it develops. So really, what I want to highlight here, of course, I did not have the time to dive into that last section as deeply as I'd like to. Please refer to that previous video if you feel that this wasn't covering the survivorship portion as much as you'd like. But what I want to highlight here is that the right test depends on the right question. It depends where you are in the cancer journey. Are you someone who's concerned about risk? Be it you have a strong family history, or you are someone that just particularly wants to ensure that if you do get cancer, you're catching it earlier than you would if you hadn't done any of these investigations. So that's where risk assessment comes into play, routine screening, making sure we're up to date, and adding things like Gallery or even RGCC. Specifically for an active cancer diagnosis, we are really looking at RGCC for those more advanced, precise medical decision-making options, and then personalized surveillance plans, making sure that when we're getting our routine blood work, CMP, CBCs, we're also including potentially previous markers that showed elevation when we did have cancer show up in the body. Certain CA-125 markers, there are different markers that we can point to and look towards that show the body's terrain, that show that we're predisposing our body to a cancer-like environment. And those can be part of a personalized surveillance plan as well in terms of blood work and ensuring that we're really being on top of our care. So if you fall into any of these three categories and feel that you need support in what decisions to make, this is really our clinical decision tree. We're concerned about risk. We might have active cancer. We might be a cancer survivor. And we're really trying to make sure we're targeting each of these bullet points to the best of our abilities and ensuring that every test is answering a different clinical question. And with the support of a practitioner like myself or someone in your area, you are really giving yourself the best ability to ensure quality of life and a strong response to cancer care and treatment if that is your path that you're on. So your next step starts with a conversation. I would like you to ask yourself, know your question. Are we in one of these three categories? Are we unsure if we're in one of these three categories? That starts with a conversation with your oncologist or a naturopathic practitioner like myself, who works towards providing adjunctive oncology support, those who deal with the side effects of cancer care treatment or are looking for more advanced ways of supporting the terrain in their body so that the environment, the molecular environment, the biologic environment, the immune-based environment in the body is at its highest optimal to prevent any potential cancer diagnosis down the line, with also proper screening protocols to say that if cancer were to develop, we're catching it early. And then really taking action, scheduling consultation so that we can, start the plan in terms of, either preventing cancer from developing, treating cancer if you do have it right now, or preventing reoccurrence. And this brings us towards the end of our presentation. But, like I mentioned, we have previous videos. We have a full 45-minute video on prevention, as well as not necessarily prevention, but preventing reoccurrence itself. So what to do after treatment. You can find these at our YouTube channel, the Regenerate Health Medical Center. We have the code right here. The Instagram channel, we have more of the short form clips, 2-minute videos, 30-second videos, but we post a bunch of daily wellness tips as well, not necessarily always just these deep dives. So if you're looking for some low-hanging fruit, learning a bit about something like magnesium or why HRV is important, you'll get some nice health educational tips there. You'll also be getting some of these longer 2-minute, 3-minute clips from our webinars. And follow us, please. Monthly educational webinars, they're going to keep coming your way. We'll have one for August. We love to educate our patients. We love to education our patient base. And if you do decide to come in, feel free to call our front desk, look for either an appointment with me or Dr. Ace. And also you can schedule a discovery call, no cost to yourself. It's a 15-minute evaluation of, if you think we're going to be the right fit. Please subscribe to our social media accounts. It does wonders for us. It does wonders for our medicine to just get more outreach out there because obviously in this country, we need more support for oncology patients and just healthcare in general. So I'm very passionate about integrative care. I'm very passionate about personalized medicine and connecting with my patients, finding a way that we can create treatment options so that the plan we finally present to you and go forward with is one that's really going to fit into the lifestyle and the factors that are at play. And not a one size fits all model, but truly a personalized plan for each individual person. And some of that comes from understanding your tumor biology or understanding your risk factors so that potentially maybe we want to do more advanced screening like a Gallery test. And if you have any questions, now is a great time to either raise your hand or throw it in the chat. Of course, this video will be posted to our YouTube channel, like I mentioned. So if any of you have individuals who you feel might benefit from this information, you can send them the link. Normally, we get these up within a week of the webinar. So, take a look at our YouTube channel, look at our other videos, and stay tuned for when this one will be formally uploaded. But appreciate the time we shared today. Again, give our front desk a call if you would like to schedule a consult, and take care. It was wonderful to talk to you today. Thank you so much.